يلا نقول بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على أشرف خلق الله محمد بن عبد الله صلوات الله وسلامه عليه. Ladies and gentlemen, good morning. I'd like to welcome you to our first activity or scientific program that's been initiated by Fema Health. Fema Health is a platform. It's meant to deliver health plus all things related to women health care or woman care in general. So we started here with some focus on healthcare, particularly obstetric care, but the message and the objectives are really endless. So we're going to have more of these activities coming up. Whenever you see it on your WhatsApp or messages or emails, Fema Health means something related to women's care. And I'd like to welcome you to promote this. Even come up to me and tell me that you can offer something for the care of women in general. I mean, even I had one fashion designer, she said to me, and can I do something about it? I said, of course. We have pregnant women, they'd like to design some dresses for her, whatever. So that's really something to promote the care of women in this country. It started with 2023. This is our first, actually, as I said, a program. The next one, inshallah, will be next month between the 16, 17, and 18 of February. And it's called Fema Health 2023. This is the annual meeting of Fema Health. Inshallah, 2024, we're going to have Fema Health 2024 every February of every year, inshallah. So that's going to be in Al Meridian Hotel, and it's really a big conference, 3 days with a pre-congress workshop on hysteroscopy and colposcopy, then 2 days conference on women care, including benign gynecology, gyne oncology, breast diseases. It's not breast that related to the breast surgeon, no. Breast cancer and infertility, breast cancer and in pregnancy, breast cancer, reconstruction and all these things that can be delivered in that session. In addition to sexology, we're going to have quite a few subjects related to that one, inshallah. That will be for next month. Now, today, really, I'm honored here to have respectful chairpersons, speakers, who really were very happy to see them actually coming forward with this to help me to run this program during the whole day. By the way, it is accredited by 8 CME hours from the Saudi Commission for Health Specialties. I will start here by this innovation. The reason I'm putting here this part actually is to thank our sponsors. Of course, without sponsors, we cannot run a place like this. I mean, I really thank them for their contribution, and I'll mention their names as I go with this presentation. But first of all, نقول بسم الله الرحمن الرحيم. هنا صوت. صدق الله العظيم. المخاض وردت في القرآن مرة واحدة. It's the only word that is mentioned once in the Quran that's related to the care of women. When God wanted to give care to Maryam, he actually made the whole mission that really meant for us to carry on according to his citing. So in our language, makhad, somebody in labor, okay, and created the place, makanan qasiya. Not only that, but also it's a well-equipped. So that's the main thing is whenever you have somebody in labor, should go to the hospital where we work. Okay, this is the place, and this is supposed to be the one that should be well equipped. ربنا سخر لها تحت كسارية طهل. This is something that's been all done and equipped by God for Maryam just to give birth. Now, this is the mission we're going to take today to improve our practice, to give the best we can do for our birthing woman. If you look at this numbers actually شغال هذا yes, current world population. I registered this just last night. So in fact, it's 8 billion plus. Just last, I think, November, the baby number 8 billion was born in Philippines. And they had a bit of celebration there. That's baby number 8 billion. Now you can see the number, about 12 million since been delivered in the past 2 or 3 months. And the clock is running. Actually, if you put it today or this minute, you'll find different numbers, but just for the sake of the presentation, I took it this way. So just to show you, the birthing is just something that we cannot really stop. And this is how, this earth is being popularized. Now, researchers say that low-income families spend nearly 20% of their annual income for medical costs during the year of pregnancy. Half, 1/5 of their income just for the care of the woman during pregnancy and postpartum. But what is really most important is the increasing, skilled attendance has been really the message that's been put out by the WHO for the 5th Millennium Development Goals to improve maternal health as goal number 5. So this is very important and has been really addressed by on a global message. And the reason is that only 57% of women delivering has been attended by skilled attendants. Imagine 40% of our women, of our ladies who are having babies, unfortunately being attended by unskilled person or attendant. So this is why I think we need to have more of this. We need to concentrate on this. We need to improve our practice in this area. This is why actually we're having this. I really would like to thank all the speakers who actually, they gave me an instant answer. Whenever I asked each one of those, they just said, yes, we're coming. I'm ready to give it a lecture. And thank you very much. And also, this has been supported by many companies who actually been, two companies who've been very helpful, and they want to promote also some new innovations that they are selling to us, which improve our skill in the delivery room. So we'll hear about neonatal obstetric gel first.
Nothing is so incredible as the development of a baby in the uterus. A pregnant woman carries the miracle for 40 weeks before she delivers her baby to the world. Delivery is not an easy task. While a mom pushes during labor, the baby gets pressed down through the vagina and the perineum. That pressure through the very tight birth canal depletes energy and creates high forces of friction, which can be felt as a burning pain sensation and which leads to the most predominant outcome of vaginal birth, tears. Sometimes doctors have to perform a procedure called episiotomy, in which they cut through the perineum to help release some of that pressure, making a wider opening of the birth canal to help the baby get out. According to the American College of Obstetricians and Gynecologists, vaginal birth might be associated with a number of risks, such as 20 to 40% of total deliveries may end with cesarean section. 50 to 60% of vaginal births have different degrees of vulva, vaginal, and perineal tears. Selective episiotomy rates range from 8% to 59%, median 32%. Or routine or liberal episiotomy with rates from 51% to 100%, median 83%. Anal sphincter injuries occur in 0.25 to 7.31% of vaginal births and can result in severe morbidity, including anal incontinence, perineal pain, dyspareunia, and emotional distress. Operative vaginal delivery rates are between 10 to 15%. 10% of the women experienced a prolonged labor. The prevalence is documented from 8 to 13%. To find a technology that can help to overcome natural birth complications, can help to facilitate the baby birth, and helps to protect the mother and her baby was the challenge. For that reason, neonatal obstetric gel was invented. Neonatal obstetric gel covers the birth canal and forms a thin bioadhesive gliding film on the vagina that reduces the opposing frictional force to vaginal childbirth. Neonatal obstetric gel is applied repeatedly from the active stage of labor until the baby is completely delivered. Studies show that natural birth with neonatal obstetric gel can be much safer, easier, and faster, and result in an intact vaginal wall and perineum, reduction of operative vaginal delivery rate by 34%, reduction of cesarean section rate by 19%, reduction of first stage and second stage of labor time by 32%, increased perineal integrity rate by 37%, and enhance APGAR score at first minute. Neonatal is safe to use with no active pharmaceutical components or any ingredients of animal origin. Non-allergic, non-pyrogenic, and phthalate-free. Kind on mucous tissues and eyes. Fully biocompatible. Have a safer, easier, and less painful delivery, overcoming the risks of tears, lacerations, operative assistance, or even C-section intervention.
Well, technology fundamentals, they're having their booth outside, so you can check with them about their product. And the next one is the Kiwi. Can you start?
Thank you for taking the time to watch this animation that will demonstrate step-by-step instructions needed for best outcomes when using the Kiwi OmniCup. Each step in the technique is important for the best outcomes, so please review carefully. Step 1 is to locate the flexion point and calculate the cup insertion distance. It is important to know the length of one's middle finger. The average distance from the tip of the finger to the proximal interphalangeal joint is between 5 to 6 centimeters. and that from the tip of the finger to the metacarpophalangeal joint is between 10 to 11 centimeters. The flexion point is located during vaginal examination by identifying the posterior fontanelle and then moving the middle examining finger a distance of 3 centimeters along the sagittal suture toward the anterior fontanelle. The tip of the middle finger will then mark the location of the flexion point. With the knowledge of the length of one's finger, the clinician then calculates the distance from the flexion point to the perineum by noting where the posterior fourchette makes contact with the back of the examining fingers when the tip of the middle finger is at the flexion point. In this particular example, the distance measured to the flexion point is approximately 8 centimeters. This is called the insertion distance. Step 2 is to hold and insert the cup. The clinician holds the cup on its side, ensuring as low a profile as possible, with the thumb on the tube in the groove on the back side of the cup and the index finger on the edge of the cup. 1 or 2 fingers on the other hand is used to retract the perineum, if necessary, while the cup is placed gently against the fetal head. At that point, the fingers are removed from the vagina and the clinician lets go of the handle to allow the stem to rest on the perineum naturally. Step 3 is to maneuver the cup toward and over the flexion point. Note the Kiwi Omni cup contains marks at 6 and 11 centimeters to assist the user in accurate insertion distance to place the cup over the flexion point. Once the cup is placed against the fetal head, the clinician should note where the stem of the Kiwi Omni cup intersects the posterior fourchette. If the distance is not what was measured in step 1, then use both index fingers to push the cup posteriorly in the midline of the maternal pelvis until the mark on the stem is equal to the distance calculated in step 1, which was 8 centimeters in this particular example. The key during this step is to ensure that the cup is moved along the midline of the maternal pelvis and avoid the natural tendency to push the cup laterally. Step 4 is to create vacuum and exclude the maternal tissues. Initiate cup seal by increasing the vacuum using the palm pump. Check that no maternal tissue is trapped underneath the cup by gently sliding one's finger around the anterior and lateral portions of the cup. Increase the vacuum to 600 millimeters of mercury, 0.8 bar, 80 kilopascals, the top of the green zone. Step 5 is to direct traction along the axis of the pelvis, using the finger and thumb technique to avoid cup detachments. Press the thumb of the non-pulling hand against the back side of the cup and place the index finger on the fetal scalp to prevent cup detachment and to monitor the descent of the fetal head. Apply traction in line with the axis of the maternal pelvis. The axis will change as the fetal head descends. In general, one should maintain a 90-degree angle between the cup and the stem of the vacuum when possible. Note, this may not be possible with the first traction effort in mispositioned babies. Ensure to time your traction with maternal pushing efforts. Kiwi Omni cup pictured here contains a traction force indicator, which is designed to measure the force exerted during traction. It provides immediate visual feedback to the clinician as to how hard one is pulling. It is especially valuable for training and documentation purposes. During contractions, gradually pull on the device to assist in the delivery of the fetus, but take care not to exceed the recommended force of 25 pounds or 12 kilograms. It is recommended if one reaches the force range indicated by red, greater than 20 pounds or 9 kilograms, proceed with caution. If progress is not made, then an alternative method of delivery should be considered. Finally, while delivering the fetal head across the perineum, ensure the non-pulling hand remains on the back side of the cup and the fetal scalp to help prevent cup detachment. Ask an assistant to provide perineal support if desired. Once the fetal head is delivered, remove the cup from the scalp by depressing the vacuum release button found on the Kiwi palm pump opposite the side of the vacuum gauge. Then finish delivering the fetus in the usual fashion. Thank you for watching this video on the Kiwi 5-step vacuum technique. Following these 5 steps will improve your vacuum delivery outcomes. Not only will they increase your success rate, but will also help decrease complications. For additional information, please visit www.clinicalinnovations.com. See package insert for full instructions, warnings, contraindications, and precautions.
Okay, well, Medical Innovation, also they have their booth outside. You can visit them and check their products. I hope you got my message from introducing these 2 instrumentations or innovations. Let's reduce our cesarean section rate. Okay, so we'll do all what we can, gel, instrumental, whatever, but please, no cesareans. At least we can whenever possible. Then I guess it comes time for a thank you. I'd like to thank the sponsors, I'd like to speakers, I'd like to thank the chairpersons, all the attendees, where they're in person. We have, by the way, also on the Zoom, we have a group attending online. Thank you for Niazic Medical Company, who really did all this preparations and all this look. Mafaza team also for their support on this stage and the audio, as well as the hotel, Radisson Blue Hotel. And above all, we'd like to thank Fema Health. Well, thank you very much. I finished here. And next, we're gonna start our program. I'd like to introduce our first 2 chairpersons. First of all, I'd like to introduce Professor Nabil Bundugji. He is consultant obstetrician gynecologist. He is also a maternal fetal medicine subspecialist. He's been the head of maternal fetal medicine unit at the King Abdulaziz University Hospital for a long time. He's a professor and a vice dean, and he actually is well written, well published. We all know him. Many of you, I think, graduated under his supervision and as a mentor. He is well liked by all the students and the graduates from medical school in King Abdulaziz University, Professor Nabil Bundugji. And the second chairperson is Dr. Afaf Tawfiq. She is actually, I like her approach because she did, first of all, her postgraduate training in Canada, in McGill, and she did the minimal invasive surgery. Tolandi, he's a great friend of mine, actually. And I remember in 2001, I had a meeting here in Jeddah, and I told him, I want somebody to come and assist me. He said, you have Afaf there in Jeddah. And we did a myomectomy, laparoscopic myomectomy that time. So, and at the same time, she had done a second, actually, subspecialty, which is maternal fetal medicine. And now she is a consultant obstetrician gynecologist, maternal fetal medicine subspecialist at King Faisal Specialist Hospital. So please, Dr. Afaf Tawfiq, I'd like you to welcome both chairperson for their arrival, and they will run the program for us. So, في مايك لهم.
Good morning, everybody. Always a pleasure to be with such distinctive speakers. It's a great opportunity for us to gather in such a lovely day, and we can thank enough Prof. Hisham Arab for his great presentations and a great experience and great arrangement for such an educational event. I would like to present our first speaker, who is Dr. Nadia Al-Hazmi. We know Dr. Hazmi, she's one of the very highly motivated and self-starters who been, mashallah, in our practice for the longest time ever. She did her training in obstetric and gynecology, and then she pursued for maternal fetal medicine fellowship in King Faisal Specialist Hospital in Riyadh. Then she established, mashallah, she's been a senior surgeon. She's running the placenta previa Creta in Creta and peripartum hysterectomy center. She has a great experience in ultrasound diagnostic, and she is also one of the instructors and lecturer and speaker in a variety of conferences. I'm very pleased to present her. She is one of our consultants in obstetric and gynecology at the Maternity Children Hospital, and she has been an executive director in the medical services. I'm very interested to listen and be part of the listeners to her presentation in mother-friendly childbirth. So thank you so much, Dr. Nadia.
Okay, شكرا. أول شيء صباح الخير للجميع. Thank you, Dr. Afa, for your kind presentation. I'm really happy to start our gathering with this lecture. Just a small reminder that the childbirth is a natural one, and the less intervention is the better outcome. My lecture will be very short. Hopefully, I will finish less than 20 minutes. And I'm going to just run with you how we can make the labor as natural as possible. So the Mother-Friendly Childbirth Initiative was initiated in 1990, and it was part of the breastfeeding promotion as well. Then in the 1996, we start to separate them from each other. They complete each other, but we were, as obstetrician, focused in the maternal part of it. And the main corner of it is the promoting of evidence-based maternity care in the hospital, clinical and community setting. And this is where our aim of this presentation. There was a philosophy behind the initiation of this care. And the philosophy is the birth is normal physiological process that does not need the current medical intervention for active management in labor, especially in low-risk patients. Then providing the mother and the baby where they have their own relationship from the day one in pregnancy is unique. And we need to enrich that and keep it as natural as possible. So by the end, they will have this unique relation between the mother and the newborn without unnecessary intervention throughout the pregnancy and birth as well. Baby should be acknowledged and treated as aware of sensitive human being that they are at that time of birth. The rest of the list is it should be midwifery module of care. Because whenever they are the one who are providing the care of those patients, they are not patients, those ladies, we will end with by less episiotomy, less cesarean, and less unnecessary intervention. Breastfeeding provides the optimal nourishment of your newborn and infant, and last but not least, safe birth practice in all hospitals. This is the 5 main principles of the initiative, that normality of birth and respect of the physiological process, as it have been mentioned in the brief presentation by our prof, that everything is natural, everything is as natural as possible as it was in that verse of Quran. Then empowerment of the ladies. They should choose where they deliver, how they deliver, and all the circumstances around labor, it should be patient focused, and they should have a part in taking that decision. autonomy right of the patient to make informed choices for all the intervention I have been mentioned, and do no harm. Physician reduce unnecessary medical intervention, and we are going to mention what are these throughout the lecture. And responsibility shared between physician and patient. We stress that it should be patient-focused care. We have a long list of benefits, and these are the most important point, that we will increase the satisfaction and resulting in better compliance to medical recommendation, improved outcome, increased job knowledge, satisfaction, and attention among physicians and nurses. And now we are going to privatization of all the services. So this is a very important point. Then promote evidence-based practice resulting in better outcome of the mother and infant. Increase the cost saving by shortening the time where the lady is spending in the hospital, and reducing the unnecessary intervention, which some of them are costly as well. Last thing, again, we are increase the repeated business of doctor, as I have mentioned before. For the babies, still there is benefit that we are lowering the complication, starting by morbidity and sometimes mortality. And whenever the birth is natural, as much as we can, the breastfeeding will be increased, and it will be higher and higher. And last but not least, the mental well-being of the mother, having natural, satisfying experience, she will end with less blues and less suffering afterwards. Okay, so the 10 steps which have been adopted by the initiative have been published in 2007, and it have been published in Journal of Perinatal Education. So we start by the steps. There are 10 most important steps, and recently it have been increased to 12 steps. So I'm encouraging everybody afterwards to go and read about the extra 2 steps. So these are unrestricted access to birth companion of her choice, including father, partner, the children, family member, and friends. We know that the benefit of having a companion during labor, she will have less pain, she will have more chance of having vaginal delivery, less intervention regarding the pain management, and as I mentioned before, higher satisfaction. Then unrestricted access to continuous emotional and physical support from skilled women, like doula or labor support professional, where their part has nothing to do with the emotional support, rather than the lady will understand what she's having during labor, how she can breathe, how she can bear down, and how she can have support during the contractions. Then the access of professional midwifery care. The second step is provide accurate descriptive and statistical information. So if I decided to deliver in King Faisal, I should know whether I can have doula or not, whether they are going to do premature rupture of membrane, what kind of pain management they will offer me. So what this is their section rate, what the vaginal delivery rate. So I will elect to deliver there or another facility according to their baseline statistic. Step 3 is provide culturally competent care that is care sensitive and responsive to the specific belief and value. For instance, we have a lot of ladies in our culture, they don't want to deliver with a male, or the opposite. They just want male to take care of them. So that should be respected from her point of view. Then we should provide the woman freedom to walk, to move around. And when we started in my institute, starting to adopt few of these steps, we had the resistance from our obstetrician, rather the midwife. And eventually we went, me and my midwife, since they are well-trained. Now we have ladies who can roam around, they can adopt the certain position where they would like. We have less and less episiotomy done in those ladies, because it's basically what? نايمين الناس ولا لا? Basically, midwifery care. All right, has clearly defined policy and procedure for collaborating and consulting through the perineum. So it's preparation before. So while she's doing the antenatal care, she should know, and we should prepare her for whatever coming, and prepare her as well for the post natal support and breastfeeding as well. And now we have the National Safe Birth Program, where all these components have been adopted, and there is a very well formed program adapting these steps without mentioning them. All right, so this is a very important slide, and I want all our residents just to remember it. There is dozen of unnecessary intervention we are doing. Maybe 50% of those interventions have been eliminated, like shavings, enema, and the drips as well. But we are still withholding nourishment. We are still doing frequent vaginal examination, and we are still doing early rupture of membrane, and sometimes these ruptures are not necessarily. She's progressing normally. The senior come to the delivery room. How far is she? She's 8 centimeters, and she still has intact membrane. Rupture it. So this should be, as long as she's dilating normally and she has normal progressive labor, that should be stopped. And strapping the woman with CTGs all through labor, and she has miles and miles and miles of CTG underneath her. I know somebody will tell me that because of the litigation, because of the, they will come and ask at this specific moment, she doesn't have a tracing. But again, we are talking about low risk patient where they don't need these miles of CTGs. Then the suctioning of the newborn, once the newborn is delivered, we start suctioning. The baby is vigorous, and we are forcing him to go for bradycardia. So these things should be stopped. And our aim is to have induction rate less than 10% and episiotomy rate of 20% or less, with a goal of 5% or less. And I believe there was a huge campaign have been led by Dr. Fatma, but till to date, the last statistic that this is the episiotomy rate is 35%. And for the prima gravida is 70%, unfortunately. And we should have a total cesarean section of 10% or less. I'm going to present my lecture and tell you the last figure and last statistic. And we should have VBAC of 60% or more, with a goal of 75%. And we are far behind regarding the VBAC. Step 7 is educate staff in no drug method of pain relief and does not promote the use of analgesic or anesthesia drug, not specifically required to correct a complication. So a lady comes, she's afraid of pain, we do epidural. She will have for some time hypotension with bradycardia of the baby. So we'll hook her to the CTG for the rest of her delivery. And she won't be able or even to mobilize. So we need to talk to our ladies. We need to tell them what other method of pain management. And by the end of the day, if this is her choice, it's her choice. Step number 8, encourage the woman, the mother and family, especially for the sick baby or babies with congenital abnormality. We shouldn't keep them distant. They should come visit their baby, check them, and give them all the necessary care during their admission to the hospital. Then they discourage non-religious circumcision of the newborn, and I don't think that apply to us, but we should respect other religion with their other beliefs. Step number 10 is we should, as I have mentioned earlier, that we should incorporate it with the, it should be maternal baby-friendly hospital. We should promote successful breastfeeding for at least the first 6 months exclusively. All right, so this slide is just to ask the audience whether this is applicable to our community or not. everywhere we know that for the last 10 years, they are promoting home delivery or delivery in special centers. And the argument is the 5 benefits which are seeing in the screen, where we have less intervention of this few steps I have mentioned, and better satisfaction, less cesarean section rate, and by the end of the day, similar outcome compared with baby of low risk women planning hospital birth. And again, this is one of the things which they are thinking about it in the safe birth. I don't think that it's coming in the 5 years, but after 5 years, most probably it's going to be put on the ground. And now they are thinking about enhanced primary care center where they can deliver those low risk patients, whether it's applicable or not applicable, whether it's still early to introduce this. But this is just to think about it in the coming 5 or 6 years is going to be discussed again. As I have mentioned, now the initiative is international. At the beginning, it's started in USA, then North America, went to Europe, and now it's international. And they changed it to 12 steps, and they are including the family as well. So it's mother, baby, and family care. With this slide, I conclude my lecture. Thank you very much.
Thank you so much, Dr. Nadia. Very, very interesting presentation, actually, and I'm going to share a few questions with you later on after the second speaker. But thank you very much for a very comprehensive and dedicated presentation. Our next speaker, it's my pleasure to present Dr. Sabah Al. She's one of our gynecologists and obstetric and gynecologists. She's a dedicated consultant in the Department of Obstetric and Gynecology in King Khalid National Guard Hospital. She is also the BALSO co-director, and she works in King Abdulaziz Medical Center. It's my greatest pleasure to present her for her presentation, which is going to be on prevention strategies of obstetric laceration. Thank you so much, Dr. Sabah.
Assalamu alaikum warahmatullahi wabarakatuh. Good morning, everybody, and Jum'ah Mubarakah. Thank you for attending on Friday. So, starting with having some strategies to prevent for obstetric laceration. So 90% of women will sustain some sort of perineal tears during their journey to deliver a baby. And most of these lacerations do not result in poor long-term outcomes. But when the lacerations involve the anal complex, mentioning the full thickness of the rectal muscle or part of the rectal muscle, then it can be associated with a higher risk of pelvic floor injury, urinary and fecal incontinence, pain, and sexual dysfunction. So we need to know how to classify the lacerations. So Sultan described perineal laceration based on the degree of injury, and this was adopted by International Consultation Incontinence and the RCOGs. So we have 4 degrees of laceration that I know everybody knows about it. So just to review it, the first degree is when there is involvement of the perineal skin and or the perineal mucosa. The second degree when there is involvement of the perineal muscles, namely the bulbocavernosa and the transverse perineal muscle, without involvement of the rectal muscle. And the third degree is when the rectal sphincter is involved. And then we divide them into 3 categories. 3A, where the less than 50% of the anal sphincter is involved. If more than 50% of anal sphincter is involved, then this is 3B. And if the anal sphincter together, the external and the internal anal sphincter is involved, then this is 3C. It's very important to differentiate between the 3 categories of the third degree in order to be able to properly adjust and suture the lacerations. However, when the rectal mucosa is involved, and this is a 4th degree laceration, so the rectal muscle and the rectal mucosa, we call this a 4th degree laceration. A special laceration which can be missed is the buttonhole rectal laceration, where the rectal muscle is intact, but the rectal mucosa is involved. If these lacerations are missed, then the rectovaginal fistula will develop and the patient will come back with incontinence and passing stool from the vagina. So together, the 3rd and 4th degree are called OASI, which is obstetric anal sphincter injuries. And the rate is around 2.6%. However, this rate was found to be increased, and this is because due to increased awareness and detection of the 3rd and 4th degree. And this doesn't relate to the poor quality or poor care that we are giving to our patient, but because there is more awareness, there is more learning about how to diagnose and treat these patients, so the rates was increasing. So how to diagnose or how to be able to not to miss such lacerations is by careful examination of each woman after delivery and before suturings. You have to have a good lighting, good analgesia, and then you start to inspect the perineum. You look for the posterior vagina, and then you look and palpate for the rectal muscle. And in order to properly palpate the rectal muscle, you use your index to in the rectum, and you use your ipsilateral thumb to mobilize your 2 fingers together as a pin-roll motion, and this will assist the thickness of the rectal muscle. So what are the risk factors of having sphincter injuries? There are studies of from the meta-analysis from 22 studies have shown involvement of severe laceration, 2.4%, and the strongest risk factors was related to operative delivery, forceps delivery, plus vacuum assisted delivery, also related to midline episiotomy and to increase fetal birth weight. The rate was increased more if we were using combination of midline episiotomy and the operative delivery. So what to do? They have studied about what we call manual perineal protection. And manual perineal protection, where you put your left hand, the non-dominant hand, to guide the head, and your right hand on the perineum to support the perineum, and then you guide the lady during the pushing. So you have to communicate with her. And usually in the labor room, what happened that everybody is guiding one lady. So everybody is saying, push it, push, push. And the poor lady will be disturbed because of listening. Some will say push, and the other will say stop, and someone will say take a deep breath. So one should communicate with the patient, the one who is conducting the delivery, and the patient should be encouraged not to push at the time of crowning, and instead she has to blow, so there will be ease delivery of the head with the control of your left hand. Also, you have to think if the patient needs an episiotomy, this is the time when the crowning that you think if this patient need an episiotomy or not, and what is the proper angle, and we'll discuss this in the second slides. So this is another way of protecting the perineum. So in the previous slide, we saw that we are applying the whole hand or the whole right hand to protect the perineum. The other method is to protect it by 2 fingers while flexing the other 3 fingers to support the perineum. And this has to be carried out even with the forceps delivery and with the vacuum delivery. So what the evidence shows, that recent evidence studies has showed that such an intervention will successfully reduce the oasis. The second is the role of episiotomy. So what is episiotomy? Is episiotomy when we do an intentional enlargement of the posterior aspect of the vagina or perineum, and this can be a midline incision where you go with your scissor in the sagittal line around 0 to 25 degree, or you can do mediolateral episiotomy where your scissor will be directed to the ischial tuberosity and to create an angle of 45 to 60 degree. So they have created special scissors to make sure that you are getting the proper angle at the time of doing the incision, because the evidence shows that proper angle of the mediolateral will reduce the oasis. So because of episiotomy did not show, there was a conflicting data to prevent oasis. Some will show protective effect, other did not. So the evidence only support restrictive episiotomy versus routine. So not everybody will need to have an episiotomy. Only those who needs to have, then you have to perform it, and better to perform a mediolateral rather than a midline episiotomy. And also you have to, studies have shown to consider these episiotomy in cases of primaries where you are performing an operative deliveries, and less likely to do it for multiparous patients, except if you are doing a forceps delivery. Warm compression is another intervention that's being carried out at the time of labor. So it will be done at second stage of labor, where you hold a compress against the perineum at the time of contractions. And the Cochrane reviews has showed a reduction in the overall oasis, but it did not increase the rate of having an intact perineum after delivery. The fourth is the doing a massage during antenatal period and second stage of labor. So you discuss with your patient at the last trimester to start performing a perineal massage, and this is carried out by her own or by her partners by introducing the two thumbs in the vagina, 1 to 1.5 inches inside the vagina, pressing downward using a lubricant like a vitamin E oil or almond oil, olives oils. And then she's pressing downward and going in a U-shaped upward to allow stretching of the muscles, so they become more stretcher at the time of birth. Initially, she might feel some burning sensation, resistance, but later on, as long as she's carrying on with this technique, the muscles will become more stretcher and be ready to time of delivery. You should advise her to have a nail cut. Some will advise to have a shower before performing such technique. So the Cochrane reviews of 4 trials showed that the perineal massage undertaken in a woman or her partner was associated with overall reduction in the incidence of trauma requiring suturing. So number needed to treat was 15, and it was less likely that these ladies will have episiotomy, and number needed to treat was 21. This was more evident or significant in those patients with a first birth, and it was not evident with those with multiparous patient. Only the evidence showed that it reduced the postpartum pains, perineal pains in the multiparous patient. Regarding the massage during second stage of labor, the data was inconclusive, and only small randomized trials found that the rate of intact perineum first and second degree stirs and episiotomy were similar in the massage and control groups. So the evidence is for the massage during antenatal period and not during labor. Actually, the massage, if it's done during labor in improper way, will create more lacerations and injuries to the vagina. What about delayed pushing? The systematic review of randomized 9 trials that compared delayed pushing between 1 to 3 hours to immediate or early pushing within 1 hour of full dilatation found no difference in the rate of perineal lacerations and also the use of episiotomy. So delayed pushing did not reduce the risk of having oasis. Bundle care bundles, this was launched in 2016, and it was relaunched in 2021 by the Royal College, and it contained 4 elements where the patient was counseled in the 3rd trimester at around some will say at 32, others will say at around 36 weeks of gestation, where the patients were introduced to OASI to learn what is OASI and the bundle of care that to be carried out during antenatal period and time of delivery. She should be aware about the manual method of protection of the head, so she won't be surprised why the hands are be kept there in the perineum at the time of delivery. Also, because she will understand that this will guide the head for a better delivery without having or to reduce the complication. Also, she should understand that there is a conflicting data about the episiotomy, and if episiotomy is needed, then it will be only done, and it should be a 60-degree episiotomy. Also, she should understand that after delivery, she will be examined properly to avoid missing any lacerations, especially 3rd and 4th degree lacerations. And this bundle of care was introduced in UK in different centers, and still there are many studies are being done to see the effectiveness and the usefulness. There is a reductions in the rate of OASI after the introduction of OASI care bundle. So how to care if this occur? It's important to know how to diagnose for treatment and future pregnancy. So as well as we need to prevent such event to happen, it's very important to know how to diagnose and what to do if it occurs. So if you diagnose a 3rd degree laceration, then you have to give at least 1 dose of IV antibiotic before starting the procedure. An expert person needs to suture such kind of laceration. And there is 2 methods of conducting the suturing, either end-to-end suturing or an overlap suturing. Both of them had the same final results. Most of the experts will go with the overlap in cases of 3C, 3B and 3C, where the full thickness is involved. Post-operative pain is very important to be controlled in patient postpartum, and it's more important for these patients because they have gone through a very traumatic procedure, and you should avoid, you should give them a good analgesia. You should avoid a rectal analgesia in cases of 4th degree laceration in order not to interrupt the mucosal repair, and you should make sure that you don't give them opioid, because the opioid will lead to constipation and you don't want them to strain. So that's why you are giving them even laxatives. And you have to advise them for a good hygiene, starting physiotherapy, and you have to see them within 6 to 12 weeks to check if they have any symptoms and if they have developed any fecal or stool incontinence. They might show a very good improvement. 60 to 80% will have full recovery within months, up to 12 months, but others might show incontinence after years as they get old. So in summary, the perineal massage at term during last month of pregnancy, as well as warm compress during 2nd stage of labor, manual perineal support during delivery has reduced the 3rd and 4th degree lacerations, but the delayed pushing did not show any reduction. Data was conflicting in episiotomy, but remember, if you need episiotomy, then do it. And if you did it, do the mediolateral at 60 degree, not less than 60 degree. And this is the end of my talk. Thank you very much for listening.
Thank you, Dr. Sabah, for this interesting presentation for the tiers. We will leave the questions till after we finish the 4th session. The 2nd speaker will be my colleague from King Abdulaziz University, Faculty of Medicine, Dr. Elah صباحي. She's an assistant professor and a consultant anesthesiologist and critical care at King Abdulaziz University Hospital. She obtained the German board for anesthesia, and then followed by a fellowship in obstetrical anesthesia in Canada. She's currently the program director of the fellowship program at King Abdulaziz University Hospital. She's also the vice director of the residency training program at the same hospital. And she's leading the curriculum development team for obstetric and anesthesia at King Abdulaziz University Hospital. She will be talking to us about a very important subject, and I think it is probably underutilized in some areas of our country, and in some area it is overutilized. She will be talking about pain management during labor. دكتور الاء.
السلام عليكم ورحمة الله وبركاته. Good morning, everyone, and Jum'ah Mubarakah. I would like to thank the organization for inviting me here to give this topic. And I also want to thank the audience for coming this morning on Friday for this educational event. Okay. Okay. So I don't have any financial disclosure or conflict of interest for the material that I'm going to present right now. Our learning outcome, or I'm going to talk about the effect of labor pain on the mother and the fetus, and the pharmacological treatment for labor pain, including nitrous oxide, opioid, and neuraxial analgesia. So before we talk about the effect of pain on mother and fetus, we have to know the origin of pain during labor. So in the first stage of labor, the pain usually comes from the lower uterine, lower segment of the uterus and the uterine part of the cervix, and they are innervated from T10 to L1. But in the second stage of labor, the pain comes from that part also, plus the vagina and perineum and the vaginal surface of the cervix, which are innervated from S2 to S4. So we have to cover these dermatome or this area to for the patients to have for the patient not to have pain. Okay, so what is the effect of labor on mother? So with pain, the sympathetic nervous system will be active and it will release catecholamine. Catecholamine will lead to increase in the cardiac output. Increase in cardiac output, it's well tolerated in healthy women, but if you have a patient who has a compromised heart, for example, cardiomyopathy or heart failure, they may not be able to tolerate this increase in cardiac output. Another thing, catecholamine will lead to increase in the peripheral vascular resistance, including in the uterine artery. This will lead to decreased uteroplacental perfusion, and that will affect the fetus later. Pain also, during contraction, the patient will have a period of hyperventilation that followed by period of hypoventilation when there is no contractions, and that might lead to maternal hypoxia. Also, pain can affect psychologically on the mother herself and might lead to depression later. So, what about labor pain on fetus? So there is no direct neural connection between the mother and the fetus, but the labor pain can affect the fetus indirectly. As I said before, the mother might have a decrease in uteroplacental perfusion and hypoxia that will lead to decrease in oxygen delivery to the fetus. So it is really important to again, this effect can be tolerated in a healthy woman, but not in someone with a disease or compromised mother or compromised patient. So now we have different ways to treat labor pain. So either we have non-pharmacological ways or pharmacological way. I'm not going to talk about the non-pharmacological way because it's not my scope. I'm going to talk about only the pharmacological. So we have nitrous oxide, opioids and neuraxial analgesia. I'm going to start with nitrous oxide first, which is very common. It's been used for a long time, for decades. The mixture that we usually use is 50% of nitrous oxide and 50% of oxygen. If we have more than that, more than 70% of nitrous oxide, the mother might have a hypoxia. It's self-administered, non-invasive. It is a low potency, the nitrous oxide, which means the margin of safety is very large. It's odorless, non-irritant to the airway for the mother. It has a fast onset and fast offset, which is good for the nature of the contraction and labor pain. We don't want any drug that has a long duration of action for the mother. As I said, it's a lower cost. I feel it's non-invasive and there is no metabolism. How does the nitrous oxide work? So in general, volatile anesthetic, we don't have, the mechanism of action is not that clear, but they say that the nitrous oxide, it works on the N-methyl D-aspartate receptor. It inhibits that receptor, which is an excitatory receptor, which causes the sedation effect. And the analgesia effect, it comes from the opioid receptor. The nitrous oxide secrete endogenous opioids. What about side effects? So the side effect on the mother is nausea and vomiting, which is very common. It can cause dizziness and drowsiness to the mother, and occupational exposure that happens if we don't have a good scavenging system. And what about effect of nitrous oxide on fetus? There is no data exists to suggest that there is an effect of nitrous oxide on the fetus, on the umbilical cord gases, on respiratory rate or heart rate. So now the question, is nitrous oxide effective to relieve labor pain? So this is a systematic review. They included 58 studies. Only 2 of these studies had a good quality, methodologically were good quality. 11 were moderate quality, and 48 were poor quality, okay? They concluded that nitrous oxide or neuraxial analgesia is definitely superior than nitrous oxide, but nitrous oxide by itself, we don't know if it's a good analgesia for labor pain because we don't have enough data. The other modality is systemic opioid. So opioids works on opioid receptors, and we have 3 types of opioid receptor, the mu, kappa, and delta. Some of them responsible for pain, some of them responsible for side effect, and some of them responsible for the euphoria effect. So in general, the side effect of narcotics or opioids are nausea and vomiting, constipation, pruritus, which is very common with morphine, respiratory depression for the mother, hypotension, and bradycardia. And almost all narcotics cross the placenta, and they also exert effect on the fetus or the newborn. So it leads to decreased heart rate in the fetus, decreased Apgar score after delivery, respiratory depression, neonatal abstinence syndrome if the mother is using narcotics for a long time, impaired early breastfeeding, and neurobehavioral changes. So I'm going to talk about some of the narcotics that we are commonly used in labor and delivery. Number 1, meperidine or pethidine. So pethidine is the first narcotics or synthetic narcotics that's been used in labor and delivery. So it does cross the placenta. We can give it IM or IV. This is the recommended dose. The peak effect of the pethidine or meperidine is usually seen after 45 minutes. So it's not immediately. And the duration of action is 2 to 4 hours. The important thing with the pethidine, it does metabolize in the liver and it produces an active metabolite. It's called normeperidine. Normeperidine does cross the placenta. It is a potent analgesic, and the duration of action of the normeperidine is 2 to 3 days. So and المشكلة I wrote all my notes for this study in the presentation, but I don't have a laptop, but inshallah I remember. So this paper, it looked for the effect of different modality of analgesia on maternal labor or on someone who is in labor. And the effect of the analgesia on the fetus itself. So they say that pethidine, if it's given so pethidine in general causes respiratory depression for the neonate after delivery. If it's given repeatedly, 3 hours before delivery will lead to the greatest respiratory depression effect on the fetus. But if we give it within 1 hour before delivery, the respiratory depression effect is less. This is number one. Number two, it has also some neurobehavioral changes on the baby that is seen even days after delivery, which one of them is decreased breastfeeding from the mother. Well, they are not able to do the proper sucking from the mother. Type. The other narcotic that I'm going to talk about is morphine. It also crossed the placenta. It is given intramuscular, intravenous as pethidine. The dose, as it's shown here, the peak effect if it's given intravenously is after 10 minutes, and the peak effect after intramuscular is 30 minutes. The duration of action, 3 to 4 hours. So as pethidine is considered long-acting narcotics, and it does metabolize in the liver. 30% of the metabolism is active, and it's also potent analgesia. It causes respiratory depression for the mother and also for the fetus or the newborn after delivery. So then we have fentanyl. Fentanyl also crossed the placenta. It's usually given IV. So we can give fentanyl in different ways, but in labor and delivery room, we give it either intravenous boluses or we can use a PCA pump. So the dose, as is shown here, the peak effect 2 to 4 minutes, which is good for the nature of labor pain, because the contraction, they appear quick and they go immediately after 1 to 2 minutes. The duration of action, 30 to 60 minutes, and it does not have an active metabolized. So the fetal or newborn side effect is less. And lastly, we have remifentanil. Remifentanil also, it's more potent than fentanyl and morphine. It does cross the placenta. We usually give it to the patient as a PCA, not at bolus, IV boluses. The doses here, the peak effect after 1 minute, 1 to 3 minutes, you see the effect of the narcotic on the patient. Duration of action is 6 minutes, which is good. We don't want a long-acting narcotic, and it doesn't have an active metabolism. But the issue with the remifentanil, so this is also a narrative review. They looked at the effect of remifentanil during labor pain on the mother and on the fetus. So if we want to compare the remifentanil with the other narcotics, it had the least respiratory depression on the fetus. But the problem with the mother, it can cause a lot, well, it causes respiratory depression on the mother, hypoventilation and apnea. So the recommendation is, if you want, first of all, remifentanil should not be a routine analgesia modality in labor and delivery. It should be used only if the patient has contraindication for neuraxial technique, because neuraxial techniques or epidural is superior than the opioids in general. So if the mother has a contraindication for epidural, we could use a remifentanil. If we want to use remifentanil, then we have to have a close supervision on the mother and monitoring, respiratory monitoring, and there should be one-to-one nursing or midwife care to the mother. And if there is any side effect, we should use naloxone. So if you are using narcotics in your labor and delivery ward, so then you have to know the dose of the naloxone and how and should be available all the time. So naloxone is opioid antagonist, and this is the dose 1 to 4 mics per kg. The duration of action of naloxone is 30 to 40 minutes. So just put in your mind, if you are using a long-acting narcotics like pethidine or morphine, and the patient does develop a side effect or hypoventilation, and now you want to resuscitate her, give her naloxone, but the naloxone ends after 30 minutes or 40 minutes, and then the effect of the morphine or pethidine will start again, and the patient will go into hypoventilation again. Okay, so also monitor the patient. When you give the patient naloxone, just keep the syringe next to the patient, because maybe after an hour she needs another dose of naloxone. Okay. And also it reverses the side effect of narcotics and also the analgesic effect of narcotics, not only the side effect. طيب, now I'm going to talk about neuraxial labor analgesia, which is epidural, and I'm going to talk a little bit of anatomy, some indications and contraindications, complications, techniques, how to maintain analgesia, and lastly, the medications that we use. So, first of all, where do we place the epidural catheter? So, as I said before, we have to cover that area between T10 and S4. So we usually place the epidural in the lumbar region because it's in the middle between the thoracic and the sacral region, and also the level that we usually place it, it's between L2, L3, L3 or L4. Okay, after we place the epidural, how do we know that we are covering the area that we want to cover? So by you doing an ICE test, the pain fibers usually run in the spinothalamic tract along with the temperature fibers. So if the patient or if the epidural covers, for example, that the dermatome from T10 to L3, okay, let's say, so she will not feel contraction in her abdomen, and at the same time, she will not feel the temperature of the ice. So what we usually do after we're giving the bolus to the patient, we let the medication works, and after 10 minutes, we do an ice test. We bring an ice, we put it in the patient abdomen, and we check right and left, and if the patient does not feel the temperature of the ice, if it's not cold, so that means it is covering that area. So we check the abdomen, and then we can know if we did reach T10 or maybe the epidural or it's low and we have to give the patient more bolus. So we can or top up bolus to increase the level. So what are the indications of neuraxial techniques? So patient request, if she wants to have an epidural, then we have to give her the epidural. Gestational hypertension, because it does decrease the blood pressure, and multiple gestation, the patient is pregnant with twins and she wants to have vaginal delivery. I believe that we should insert an epidural because the risk of cesarean section is higher in those patients, and also patient with VBAC or TOLAC. As we mentioned before, assistant vaginal delivery or instrumental vaginal delivery, because that's painful to the mother. Contraindication, patient's refusal. Uncooperative patients, coagulopathy, infection at the injection site, sepsis, intracranial mass, hypotension, because the epidural or neuraxial technique will cause hypotension later, or inadequate training with technique. So if your anesthesiologist doesn't know how to insert an epidural, so don't let him insert the epidural. Maybe you have a junior resident there, anesthesia resident. So if they don't know, they shouldn't insert the epidural catheter. And also inadequate resources for monitoring and resuscitation. If you don't have that, don't do the epidural. So what do we inject? We inject local anesthetic, usually bupivacaine, ropivacaine, with narcotics, usually fentanyl and sulfentanyl. طيب. What are the maternal side effects from neuraxial technique? Hypotension. And why does hypotension occur after epidural or spinal? Because we are inserting the catheter at the lumbar region, and that will lead also to sympathetic block. The sympathetic fibers come from the thoracolumbar region. Now we are blocking that. There will be no vasoconstriction. There will be vasodilatation. That will lead to hypertension. That's why the patient should have an IV when she's getting an epidural, and we might give her a bolus of ringer lactate to prevent that hypertension. Nausea and vomiting might occur due to hypotension or due to the narcotics that we inject with the local anesthetic, pruritus from the local anesthetic, shivering because the thermoregulation effect in the affected thermoregulation control in the affected area is not well, it doesn't work very well, and urinary retention. That's why they might get an Foley catheter. So, and some complications are unilateral block. So block, it it's only on one side of the body, but not the other side. That's why we check with the eyes test. Patchy block means that the abdomen is well covered with the epidural, but there is one area where the patient is feeling the contraction and severe pain. Epidural hematoma if the patient has bleeding tendency or on anticoagulation medications. Post-dural puncture headache could also occur. Bradycardia if she has a high spinal block, and respiratory depression also if she has high spinal block and the diaphragm nerves now affected with the epidural. Intravascular injection and local anesthetic toxicity. طيب, what are the techniques for inserting neuraxial analgesia? We have a conventional epidural, combined spinal epidural, dural puncture epidural, and lastly, continuous spinal catheter. I'm not going to talk about the continuous spinal catheter because we rarely do it. We do it only on specific patients, but I'm going to explain to you the other three. So the conventional epidural or epidural analgesia, we do it in the lumbar region, and it's the standard the practice for pain relief during labor pain. So as you can see here, this needle, the epidural needle, is called towing needle. It's a big needle. It's an 18 gauge. And these colors, the white and black, it's so each color is 1 centimeter. So I know the depth of the epidural from this needle. We go into the epidural space. So the yellow is the spinal cord, the blue is the subarachnoidal space where there is the CSF, and then the red line is the dura. We insert our catheter in the epidural space, the space before the dura. Okay, so that's the location of the epidural catheter type. And in that epidural space, the nerve roots from the spinal cords comes out, and then there, where we inject our local anesthetic, it will affect the nerve root. Okay, so the onset of analgesia usually occurs 10 to 20 minutes, so it's not immediately. And hypotension could occur after we give the patient a bolus, but the hypotension is slow, not with the spinal anesthesia, it's fast and acute. Combined spinal anesthesia from its combined spinal epidural, from its name, we do spinal anesthesia and we insert an epidural catheter. So either in the spinal anesthesia, actually, we inject our medication in the subarachnoidal space. So we make a dural puncture. We go to the subarachnoidal space where we see the CSF, and then we inject our medication. Okay, so either we do a spinal anesthesia at one level and then epidural catheter on another level, or we do needle through needle technique, as you see in the second picture. So with the epidural catheter, we go into the epidural space and we stop, and then we bring the spinal needle, insert it through the epidural needle until we puncture the dura and reach to the subarachnoidal space. We inject our medication, we take the spinal needle out, and then we insert the catheter through the epidural needle in the epidural space. Okay, so the benefit, now we have both spinal and epidural. So the benefit is faster onset of pain relief because the spinal medication is injected in the subarachnoidal space and they work immediately. It provides better labor analgesia, less unilateral block, less catheter failure, because you see a lot that we insert an epidural catheter, but it doesn't work at all, and high maternal satisfaction. But the problem is with the spinal medication that we inserted in the subarachnoidal space. It can lead to maternal hypotension, and it's more severe, more acute. Maybe you see that in the cesarean section when we do spinal anesthesia. That's why we have to measure the blood pressure very frequently. And the opioid itself will lead to pruritus, even more worse than the epidural itself, and increase incidence of fetal bradycardia. Why did this happen? So the fetal bradycardia that happened after spinal anesthesia is transient, okay? But it happens because we are suddenly relieving the pain from the mother. Suddenly, there will be no catecholamine in the body, and the epinephrine, has a tocolytic effect. So we don't have epinephrine, there is no tocolytic effect, and the uterus will go into uterine hypertonus. This will lead to decreased uteroplacental perfusion, but it is transient. This is a meta-analysis that compared between combined spinal epidural.
باقي دقيقة دكتور الوقت.
طيب, okay, compared between combined spinal epidural and epidural technique to see if there is any fetal heart rate changes, and they found it's more with the combined spinal epidural technique. And then we have a dural puncture epidural. In dural puncture epidural, we do a combined spinal epidural, but we puncture the dura and we do not inject anything. So what we do, we create a hole. The medication will move from the epidural space to the subarachnoidal space slowly. The study is a randomized controlled trial that compared the three modality: epidural, dural puncture epidural, and combined spinal epidural, and they found out the analgesia is faster in the combined spinal epidural, then the dural puncture epidural, then the epidural catheter, and the side effect is less. If you want to compare the dural puncture epidural and combined spinal epidural, the side effect is less. Okay, so better analgesia than the epidural and less side effect than the combined spinal epidural. How do we maintain analgesia? Either we use a continuous epidural infusion, or we do a PCEA, patient's controlled epidural analgesia, or programmed intermittent epidural bolus, or combination, any of them. Okay, the conventional or continuous epidural infusion, the one that we usually use everywhere, or the first modality that we usually used, okay, it has more maternal hemodynamic stability, and it decreased workload for anesthesia provider, because before this invention, the anesthesiologists usually come and give the patients boluses of local anesthetic. In patients controlled epidural analgesia, the patient will have the pump next to her, and she will administer the local anesthetic whenever she feels pain. So there is more flexibility and more maternal satisfaction comparing to the combined to the continuous epidural infusion. And if you compare both the continuous infusion and the patient's controlled epidural analgesia, there is less motor block. Okay, in the PCEA group, they have total dose of local anesthetic is also less, better analgesia, and more maternal satisfaction. In the programmed intermittent epidural bolus, the pump will give the mother automated boluses every 45 minutes or 6 minutes as we program it, even if the mother doesn't need, so the mother doesn't have to press, and even whether she's in pain or not, she will receive that bolus. Okay, if we want to compare the continuous epidural infusion to the programmed intermittent epidural bolus, the programmed intermittent epidural bolus is better because the distribution of the local anesthetic is uniform all around the spinal cord, and there is a better analgesia and better spread. So the solution that we use, or medication that we use in the local anesthetic, before it was a high concentration of local anesthetic, which caused motor block and then more vaginal delivery and less maternal satisfaction. Now, okay, now we are using a lower concentration of local anesthetic, 0.1% or less, which caused less motor block, less vaginal delivery, and good pain quality control in both groups. Okay, it does not, the local anesthetics with diluted local anesthetics does not lead to increase in the second stage of labor. And also, this meta-analysis compared patients who used epidural with diluted or lower concentration with patients who did not receive an epidural, and they found that the cesarean delivery rate is the same in both groups, and there is, it doesn't cause or increase risk of cesarean delivery. And lastly, if we add narcotics, if we add narcotics to the local anesthetic, this will lead to reduce in the local anesthetic dose and improve the quality. So take home message, I'm sorry, it took a long time. So it's important to treat labor pain in compromised patients. Neuraxia technique is the best, and we use a diluted local anesthetic. Nitrous oxide is safe option, but we don't have sufficient data or evidence to prove its effectiveness in labor pain. And if we want to use narcotics, we have to monitor the mother and the fetus. Thank you very much.
Thank you, Dr. Ala, for the Excellent presentation.